All right. So this is the last of the 3 PowerPoints I'm utilizing for this section. Okay. And really so it's the last of muscles. This is really a little bit on think of some additional information about kind of what optimizes muscle activity. Might be the way to describe it. And then the remaining part of it, we don't do any, I may mention the word or show you some illustrations of cardiac muscle. I am leaving all of that for AP2. It's really where it's best evaluated. Whoever is doing AP2 with you, I don't know who the instructors are. I'm sure my colleague, Dr. Maurer, who's over in that center room, not now, but if you're coming to class, you might see him doing micro over there, is probably going to be at least pick up one of the sections. Dr. Robbins, again, has a lot of the labs. He has other classes he teaches in the spring, so I don't know if he's going to be able to get all those labs in. And thankfully, the lab will be standard length. Okay, so there'll be a full semester. And like I said, I'm doing micro sections, and depending on when you're registering, if you're going to be taking it, I think there's 3 sections. I got 2 of them. I like teaching the micro. And again, for you folks who are here, I am more than happy. Just if you have emails about what's going on in AP2, if you have some questions about material, if you need some clarification, if you want to come in and say, hey, this is what we're studying, can you give me a heads up? That's what I'm here for. Why I'm here. It's easy to find out office hours and stuff like that. Moving on. So we start here. The main factors about how powerful a muscle is. They start with, well, it makes sense. How many fibers are stimulated? Okay. And again, that is a really big player. So the more we need to lift something, if it's something very light, we don't have to have a whole lot of things. If it's something very heavy, we have to bring in more fibers. It's what I like to call intuitive. And a lot of this it means it makes sense. It's funny. I think you'll learn better with things that are counterintuitive, but these are ones that are pretty obvious. And if it's obvious to most people, it should be obvious to the students as well. The size of the fibers. Okay, how do we get stronger? We can't make any more muscle. It's finite. We're born with all the skeletal muscle we're ever going to have. They don't undergo mitosis, but they can hypertrophy or grow. That's the interesting thing about it. And the way that it is done is basically through, it's the type of thing, if you're ever interested in it, and that was in that one I sent you. I was talking about things like muscle milk and creatine powders and all that type of stuff. Effectively, those I'll just make the point again. There's nothing wrong with eating those as supplements. They're fine. Proteins are fine, wonderful supplements. It's not magically going to put muscle. What it's going to do is provide you with the building blocks to make muscle. So you have more ingredients, and if you're with appropriate other nutrition, and that's a supplement, if you're with a proper exercise program, you should be doing it under a guidance of a trainer or a physician or somebody who's involved in exercise. Then that's how it makes muscle. The mistake people make, I think, is they do that. It's too easy to do things online today. You look it up. How do I make my muscles bigger if I want to take protein supplements? And you really, it's a little more complex than that. Young people are things are pretty forgiving. If it starts to cause a problem, it's pretty easy to stop. As you get older, it can cause problems that aren't so easily correctable. And again, that's an intuitive point. But that's really something that you have to understand. And the opposite of that is a thing called atrophy, which I think they talk about here. And atrophy is when you're not using it. For you folks, maybe that you had an injury in a sport or an athlete, or you had hopefully nothing worse than a car accident, that the car got damaged and maybe you got a little damage. And you couldn't use it, you had to be on crutches or in a splint. In the old days, we had casts on, and the trouble was that you couldn't use it or exercise it, and it basically shrank. But young, healthy individuals, a couple of weeks, comes back. Children, it's almost miraculous how it's like it's not there, and a week later it's there. So again, you want to avoid permanency. And I think there's something about that here as well. And so that we call it atrophy of disuse. We used to see it a great deal with casts. Because we didn't, if you watch here on campus, if you see, and particularly with the athletes, if they's in, most of the time they're in a brace. Gotcha. Most of the time they're in a brace. Most of the time they're in like one of these sort of like a plastic sandwich cast where it's, they have a bottom and a top and it's secured by Velcro or straps. And the beauty of that is you can do, if there was a wound or skin problems, you can take it off. You can do electrical stimulation treatments. You can do massage. You can do aspects of rehabilitation, even while the bone and the injury itself is healing. It's changed a lot over the years. Or we basically just put it in a cast every X amount of time, 2 to 4 weeks, we change it out. So, and the other thing, and this is the most important, frequency in muscles and in nerves, frequency is amplitude. In nerves, particularly, in muscle, it's very much, once you stimulate it at a given frequency, it's going to reach its maximum. As long as you stimulate it continually at that frequency, it will stay at that maximum, as though we were achieving what was in that last PowerPoint that I didn't talk to you about, a thing called tetany or fusion. Basically inducing the muscle to spasm continually. And in our next unit, which is all about the nervous system, if you hear something that's loud, it's because it's triggering sensors in your ear frequently. If you feel something that hurts a lot versus hurts a little, it's stimulating those pain fibers more frequently. Loud, hot, cold, pick one. Frequency equals amplitude when you come basically to the nervous system. And really, it's applicable to muscle for all intents and purposes. And this, I think, is always the most interesting. And it's easier to show you. It's sort of the 20% rule. At 100%, that's what we call resting tension. It's when you're sitting here, all of your muscles have a certain degree of tension in them. They're not flaccid. If they were flaccid, you'd all be laying on the floor and not moving. I mean, I realize my lectures sometimes can induce that state of complete coma, and hopefully not today. See, opportunity to laugh squandered again. Thanks for the smile over on my right, left. We'll keep going. So, I mean, the very fact you're using those muscles, and we call that resting tension. If you want to fire a muscle, if you've overstretched it or overcontracted it, you can't generate force. Force, and I don't teach physics, but basically what they taught us is mass times acceleration. So acceleration is how quickly the length is shortening over intervals of time. So velocity is, it's basically how quickly the speed is changing is really what acceleration is. Like hitting the accelerator on your car when you're going 50, how quick you get to 70. If it's too long or too short, as you will see, it can't generate enough force. This is why physiologically that occurs. Here you can see the frequency of, maybe I went by it. Here you can see frequency. This is the one we're trying to get to what we call when it begins to fuse, you almost get a straight line. This is called unfused tetany, and tetany is a straight line. More fibers recruited, bigger muscle fibers, and the stretch thing is here. This, to me, it's a great graphic. I love to talk about this is resting. And so arbitrarily we assign a value of 100%. There's a certain number of actins and myosins that have already been engaged. And that creates a certain amount of tension. So the muscle's not completely relaxed nor completely contracted. If you take it, all you have to do is, now remember 80, it still works. You get to 75%. All of a sudden now you don't have a whole lot left. You don't have a whole lot of movement available. These are almost reaching in the midline. So you really have a very, very little amount. So you take someone who's trying to generate power with a muscle. If they start where it's normal, they can do that. But if we're up here, you can hardly, you're going to reach an endpoint structurally. That's what they're talking about. By the same token, now they're showing an extreme example. When it's 170 degrees, there's almost no engagement. So I can't quickly generate the power to do that. And indeed, I might get to the point where the muscle is almost become disengaged. That's another, and once the engagement's not there, then you're really damaging the muscle fiber, and you start to lose, because again, you can't replace it. So I think it's a good graphic. I call it the 80 to 120 rule. That's definitely a question about that on the exam. This is the other stuff. How fast and how long can it stay like that? Now, obviously, there's a finite amount. We could do our muscles really fast. Eventually, they're going to fatigue. We can hold something up this heavy. Eventually, we can't do it anymore. And so it has a lot to do, and frankly, it has a lot to do about heredity. Those are called the types of muscle fibers. We're all, maybe the starting point is to say, genetically, we have what we have. It doesn't mean we can't optimize what we have. You can become good at something, but the likelihood of someone who's, an average at a particular sport or endeavor becoming world class, very unlikely. That's something that's part of you, as you will see. And then how much is on it, the load, and how many more fibers we have to try to carry that load. That's the recruitment. We're calling more troops, and in this case, muscles. And it's based on the motor units that we engage. And so it all breaks down, and this is the hereditary aspect, to these three different kinds of fibers. So they break down into slow or fast. And you're going to see we have slow and fast oxidative fibers. And they say oxidative or aerobic. In this case, it means that aerobic means that we require, these are ones that we use and effectively are replenishing and revitalizing with oxygen. So basically, there's an oxygen-based requirement. And so it has to do with what happens, patterns of electrical activity, different enzymes, which is not important to us. So you have oxidative fibers and what are called glycolytic fibers. If you remember, we talked about it, or again, that's probably in that one that I sent you. I don't know whether you had a chance to listen to it, but glycolysis is something we do in what's called anaerobic metabolism. We have enough energy to use our muscles for about a quarter of a minute, about 15 seconds. We get it from ATP and other substances that have the ability to act like ATP. If you listen to it, you'll hear about that. After that, the muscles are contracting so much, blood can't get in there. Where does the oxygen come from? The blood supply to the muscle. So if those muscles are contracting, blood vessels can't get in there. So as they vigorously contract, or they have to do things very sharply and suddenly, they utilize what's called a glycolytic pathway. That's those fibers are ones that don't require oxygen to work. Surprisingly, you can generate a lot of power in them, but they're use it once, and then you have to replenish it. So they're very different. So here's the classification: slow oxidative, fast oxidative, or fast glycolytic. And muscles contain a mixture. And that's how we determine how fast they can contract, how solid they are at resisting fatigue. Each motor unit has only one type of fiber, and it's all about genetics. So, I mean, if you haven't got it by now, you're listening to somebody. I live to watch sports. I love it. It's typical about somebody who's not very good at them. Like I said, I have a vertical leap of about 1/4 of an inch. I can barely get off the ground. I mean, and it doesn't matter. Okay. So as much as I like sports that require athletics, I don't have the physical capability. I can't run that fast. I can't jump that high. I have decent but not great hand-eye coordination. I couldn't throw a baseball if my life depended on it. I could hit. Thank goodness I could do something. So understand, I was that kid because I was giant, because I was weighed like 250, 260 pounds. They put in the middle of the line. Football. It's going to be hard to move. Nevertheless, it's genetics. It's crazy. My sister's got my kind of genetics. She's very tiny. She's not athletic at all. Her husband, he's freaking, I tell you, he's 82 years old. He can shoot his age on the golf course. He weighs the same as he did when he was in college. He's 5'8", weighs 160 pounds. He's the first guy ever on every team. You choose up the team, first guy. Doesn't matter what the sport is. with any good luck, they'll stay married for 3 more years and they will hit the magic 60. So that's pretty good. That's a pretty good run. I'll find a picture. Both the same as when they met the first day of college. So the whole idea is what they're used for. Slow oxidative we use constantly every day. So those are postural muscles, big muscles in your back, your rear end, your gluteal muscles. A lot of it. The soleus is a very much of a postural muscle that's there. Sprinting and walking, okay, these are things that we use. So if we're moving relatively consistently and not extraordinarily fast, we use these. So there's other muscles. The gastrocnemius are a very good example. The other calf muscles that are there. But very, very short-term intense, like hitting a baseball, swinging a golf club, firing a tennis racket, whatever, throwing a football. Those kinds of things are glycolytics. And again, with practice, with effort, you can change some of them subtly. And really, that's the sum and substance of this early part of the presentation. That's there. And they do some comparison, which I'm not going to ask you about, the different fibers or the glycogen stores. But the whole idea, if they're glycolytic, those short burst muscles, they fatigue. Okay? And if they're postural muscles, they really don't. Use them all the time. And then obviously we have a bunch that are in between. And you can just look through it. And they talk about the fibers. And I'm not going to ask you any about that type of stuff. And obviously, if there's nothing you have to lift, the muscle can move really fast. You can do this pretty darn fast, but if you got a 25-pound weight in each hand, it might take a little bit more effort than that. So that's the greater load, the slower the contraction. And if that weight was too heavy for you, really had to struggle with it, as a lot of people might, then you're going to recruit more to try to make that lift. That's there. And that's just showing you some graphics about that aren't that important. And really, this is a good summary about the whole idea of aerobics and what they are. You're trying to increase endurance. And this is part, because I didn't give it to you in person, I would rather do this again here. The idea of aerobic exercise is, and they're giving you ones, jogging, walking, biking, swimming, exercises where you use your big muscles. And we can use them for excessively long periods of time. If you're relatively out of shape, and I certainly qualify for that. I mean, so like over the summer, probably until July or August, I'm going to the gym 3 or 4 days a week. I can get on the treadmill. I can easily do a couple of miles. And I don't run, I walk at elevation. And what my whole goal and what the aerobics are there is for me is cardio. So the whole idea of cardio is to try to get your heart rate up to a target range based on your age and hold it there for about 30 minutes. That basically exercises your heart and will develop additional blood vessels we call collateral channels. It means basically you're increasing your reserve ability. So if your heart ever has to beat faster rather, it's unlikely to fail. It's like the person who goes out and shovels wet snow when he hasn't done any exercise all year and it's freezing outside and all of a sudden they kill over with a heart attack. And believe me, it happens every winter. I look at all of the newspapers online that I look at, and you always see an article about some tragedy. It's terrible. It's tragic. I'm not trying to make light of that. So what you're doing is you're increasing the blood supply, the energy capability, the mitochondria, the capillaries, myoglobin, which is the oxygen supply, endurance, strength, resistance to fatigue. That's what aerobics are. And what you're doing when you're using those big muscles, you're marrying your heart rate to your breathing, to your usage. So rather than being able to only have enough energy to do it for seconds to a minute, you can now do it literally for hours. I mean, now I could do that if I was, and the next time, and with the gym, next time you go back on the treadmill, you can do it a little faster, you can do it a little longer, you increase the elevation, whatever activity you're doing. It grows. It doesn't take long to get back to doing it. The idea is, after that first 30 minutes, your body switches over from burning carbohydrates and the available glycogen that's in the muscle and starts burning fats. and you do a fat burn, and obviously it's very desirable because most people are doing those exercise programs in part to lose weight. A lot, particularly again, with my age, it's about cardio. I do that first before I chance the machines. Which is, by the way, the wrong way to do it. The same thing applies here. This is something that if you're this, a lot of these are about training. If you're training to develop endurance, this is the kind of stuff that you do. You try to exercise those muscles that are just by nature aerobic, and over time to develop a resistance of fatigue. And then even with appropriate exercise, you can switch some of those glycolytic, those fast use of once kind of muscles, and then you can't use them for a while until they replenish into more oxidative muscles, so have greater endurance. So and there's comments on different, so that's one. Strengthening. We use what are called progressive resistance exercises. I will qualify this. I'm not an athletic trainer. I haven't done exercise physiology with patients in 25 years. So and sports science has changed dramatically over the last 50 years. I mean, when we were in college, the trainers were really good and they could get you back. You could be running on sprains in 3 days. It was different. It was really, nowadays it's even faster. There's so much that they are able to do to get people back, unless it's an injury that takes a lot of time. But one thing that's unlikely to have changed is strengthening. For instance, the classic example is the knee. I saw a lot of people with knee problems. Once the knee was better, once it calmed down, once maybe they had a surgical procedure. At that point, to rehabilitate it, we use something called straight leg raises. So you could lie on the floor, you could lie at a table. Bed's not a good idea. It's too soft. And you would be on your back, you point your toes up towards your nose, and you lift your leg up about 12 inches, and you do that for a count of 10. Maybe you do 10 to 15 repetitions, maybe 3 times a day. The idea of resistance exercises is you start with a relatively small amount of weight, and every week or two, you increase the weight incrementally. You start with 2 pounds and another 2 pounds and 5 pounds. You can get Velcro ankle weights. You can put a paper bag with cans in it. You could be very inventive with how you do these kinds of things. There's lots of ways to do it. But by progressively increasing the resistance, you're strengthening the muscle. And the muscle basically strengthens the joint. The other one of these, when someone's had, let's say, an operation and they're stiff but their strength is good and you're trying to increase the range of motion, resistance is not part of the process. There you maybe have them just doing straightening and flexing exercises, and all you would do, maybe you have a nominal amount of weight, but you don't change the weight. You increase the number of repetitions, you increase the number of times a day. So your goal is range of motion and flexibility as opposed to stability. And that's a big deal. I have a lot of students in these, I'm going to tell you, in these roughly 110 students in these 4 sections of A and P, somewhere between a quarter and a third are in health science, and a lot of them are looking at physical therapy. This is the kind of stuff that you do. That's what you train about, you learn about when you do those things. It's extremely impressive, the type of things that I've seen. And I have one of the things that I learned, it's my family's business, which I did not go into. Rather than going into a medical field, and for very good reason, was in the supplied padding and taping materials and different kinds of adhesive felts and foam rubbers to giant sports teams, the Steelers, all the NFL teams. The business name still survives, but it's sold like big businesses do. Even small businesses are sold a number of times. My late uncle, back when the Steelers in that first run with the 70s was Terry Bradshaw when they first became famous and won 4 Super Bowls in 6 years. He would be on the sidelines. His best friend was the Steelers trainer. They retired together. They built retirement homes together in Florida. That kind of best friends. Just to give you an idea. So, and he was ahead of his time. But that was 50 years ago. And so, and everything has changed, and they're just so much more sophisticated today. How they get people back running and participating in sports, because it's everybody, if you didn't know, it's a business. Players are commodities. I know they're people, but they make a lot of money in their commodities. And this is one of the things to keep them active, because if you're not, this is called atrophy of disuse. Again, you can see that if someone's in a cast or in a brace where they can't use it, but for young people, they can recover this. The problem is, in severe cases like paralysis, after a period of time, not only do they atrophy or shrink, trophy means growth, A is without. Hyper means more, trophy is growth. So hypertrophy, grow a lot, atrophy, stop growing. Then fibrous tissue takes the place of muscle tissue, and at that point, school's out. You can't make it anymore. So this is all the thing. That's why rehabilitation is impossible. So there's a lot of this unit, not just for people in health sciences, but if people are going to work on a clinical floor, a nursing floor, there's a reason that we get 90-year-old men and women who had hip surgery up in a chair that day after surgery, and they're in physical therapy the next day learning how to move with a walker. This is part of the reason. It's absolutely true. Because we had those patients. I mean, an old lady would come in and have, typically they break their hip and then they fall, but the idea, and all of a sudden we're up for hip surgery, and and the first order you're writing post-operatively, we were the residents, once stable, once back in the room, within 2 hours, up and in chair. The rest of this first presentation, very straightforward. It's about smooth muscle. Smooth muscle make up hollow tubes. They're everywhere. Most of AP2 is looking at structures with smooth muscles, blood vessels, digestive system, respiratory tubes, genitourinary tubes. They're made of smooth muscles. They're very, very similar in that regard. What's in here? Oh, I got paper. So, let's see if I can get some. They're organized into sheets. The skeletal muscle you can see is different. Terrible. Make me look bad. I'll borrow some paper from here. I don't know whose paper it is, but it's a sheet of paper we can use. It's a long sheet of paper. This is said muscle. All of these tubes are tubes. They have an opening in the middle. It's called a lumen. Lumen. You don't have to know that for me. That's anatomy for next time. Typically, the muscles are arranged circular and longitudinal. Close to the opening, circular, longitudinal outside of it. Most of them work the way food gets moved around, sperm gets moved to ejaculation, eggs get moved down the fallopian tubes for fertilization. There's a process called peristalsis. Squeeze, push, circular, longitudinal, alternatingly. And that's how they move it. And basically what controls it are when food enters your stomach arbitrarily, little stretch receptors are there. Basically that triggers inside, it's got its own nerve complex, stretch receptors. What kind of chemical composition, depending on where it's going. Is it acidic? Is it basic? Has it got a lot of concentration? This is all the kind of stuff you talk about when you do digestive physiology in AP2, but it works the same. Squeeze, push. Forgot to get toothpaste at the store. You want to brush your teeth in the morning and it's like you got that much left. You always save the old one just in case. I'm not the only one who does that. Somebody else, you did. No, you're more organized, so you make sure you had it. What did my wife? My wife got something on her nose and started to break out. Try to remember what it was that she had on her finger. She touched her nose and started. Somebody she was cooking. It's like do you have any cortisone cream? I said, yeah. And it was like, there was nothing left in the tube, but enough that we should get some on the tip of her nose. Thankfully, that was all it needed. But that's what I mean. There's sheets and the arrangement. When you get to the stomach, it has circular ones, it has long, and it has ones that go sideways. They're called oblique. They go at an angle. And by looking at those muscles, you can see how basically your stomach, what your stomach is more than anything else, is mixing. It's a big bag for mixing. That's really all it is. It's like you put a bunch of stuff and mix it around. So they contain two sheets, the long axis, okay, longitudinal and circular. Typically circular is more around the circumference, around the opening, and closer to the opening, okay, and they alternate, and that's really what happens. So it mixes it and moves it along. You'll see this a lot. They differ. Smooth muscles differ in a lot of ways, even though we still call them muscles. They still have the actin and myosin. And the myosin heads contract, and yes, they move the actin, but it's because of the way it's shaped, it's totally different. We call it spindle shape, and you'll see it. It's narrow at the edges on the tips, wider in the middle. And you're going to see the orientation is different. And chemically, it's not the same either, and that's really important. So they're thin and short compared with skeletal muscle fibers. They don't have multiple nuclei. They only have one. They have striations. They're just not visible. Striations are about thin and thick filaments overlapping. They just have so many thin filaments. Skeletal muscle, it's about 2 to 1, thin to thick. So they overlap a lot, those A bands, and then the I bands. The difference here is about 12 or 13 to 1. I think this PowerPoint says 13 to 1, and that'll be on the test. I won't say answer A is 12 and answer B is 13. It'll be one or the other. I'm not going to nitpick about that from one author to the next. But with all those thin and so little in the way of thick fibers, you can't see the overlap very well. So the striations are there. That's why I like to qualify it as visible striations. And they don't have all those sheets. They don't have the epimysium. They don't have the fascicles and all that stuff. They just have a thin, delicate liner of endomysium around them. And they don't have a neuromuscular junction. Like this, we talked about so long. Nerves spit out of the tip of the thing, contacting the motor end plate, all the different gated channels and this and that. Different here. Does it have neurotransmitters? Yes. Are most of them acetylcholine? Yes. But it has what are called varicosities. Varicosities aren't just enlargements in a vein. That's what most people hear about, varicose veins. Post-pregnancy, people are very heavily set. People have bad veins in their legs for other reasons, typically heredity. And so the veins underneath the skin bulge, particularly when they're standing. A varicosity is just a bulbous swelling. It's sort of a roundish enlargement, as you will see. And it's in those enlargements where the neurotransmitters are. And again, most of them are acetylcholine. And they have synaptic vesicles and they have mitochondria, okay? And there is a synaptic cleft, but it's nothing like the motor end plate. And they call it they don't even call it something. They call it a diffuse junction, which you don't have to know. But it kind of gives you an idea. When the nerve is stimulated, the chemicals, just the acetylcholine or whatever they're using, there's only the other one's called norepinephrine when we get to that by the end of the course, kind of ooze out and cause the muscle to contract. It's the autonomic nervous system. When we come back the week after break, we have one more week of class. We'll be covering that system in that last week. That's the last unit for the final exam. So that's what's going on. So here we have these varicosities, and you can see the spindle shape, narrow and wide, narrow on the edges, wide at the tips. So that's what it looks like. That's there, and they're all over. There's no pattern. You don't have to be that familiar with the pattern. All you have to know that they have the varicosities are there. They have synaptic vesicles. They have mitochondria. That's it. No names of nerves, none of that stuff. You don't have to worry about it. The big deal here is it's still about calcium, but really the key player when you talk about the heart, the key player when you talk about nerve firing, the key player when you talk about smooth muscle firing is not intracellular calcium. That's skeletal muscle. The skeletal muscles contract because of calcium that's stored already inside. These are almost exclusively about extracellular calcium. I didn't say exclusive because there is some intracellular calcium. It does not play as great of a role. So the smooth muscle has a sarcoplasmic reticulum, but it doesn't have those T tubules. The T tubules, okay, were part of that membrane, the external membrane of the cell. That's not it. It kind of enters a different way, and you're going to see what happens. The sarcoplasmic reticulum does have some intracellular calcium, but most of the stuff for contraction comes outside. This is the point I made to every other class, and the same is true with the heart. These channels where the calcium comes in from the bloodstream or from the surrounding tissues are ones that we use medications on a lot. Smooth muscles are what your blood vessels are made of. When they're too tight, either there's too much calcium flowing in or there's something wrong with those channels. That plays a very important role, as well as for heart function. So the go-to medication that's been around, if you looked at it, if you're going to go into a field where you have to learn pharmacology, like nursing, you always learn about the medicines that are used a lot. They're called calcium channel blockers. You're going to see a calcium channel now. I take a calcium channel blocker and have done so for the last more than 20 years. My blood pressure is pretty good. But I keep it under control with two medicines, one of which is a calcium channel blocker. It's the go-to. Somebody my age, most of us have heart problems. I don't. High blood pressure, I do. Other arthritis. Calcium channel blockers are in the equation. If you have high blood pressure, most likely you're right. I tell all the classes, if you're going to a field where you have to learn medications or learn pharmacology, always learn the most you can about the ones we use the most. It's really important. For oddball medicines, antibiotics you want to know about. Pain pills you want to know about. Anti-inflammatories, heart medicines, kidney digestive medicines. People take those all the time. So they take some exotic thing for a rare disease. You do what we all do. You look it up. Because when you're using them a lot, you really want to know a lot about them. It's very, very true. It's like I started learning about that stuff when I was a student doctor. And I mean, I always relied on my memory, and I saw, I'm working with they were just graduated from med school, interns at a vet's hospital in Richmond, Virginia. And he's taking out, we didn't have anything digital. 1976 was the bicentennial. He's taking out a flip spiral. He's writing stuff down. And every so often he put a check mark. He says, well, this is what I do. Every time I have a medicine, I write down the medicine. If it's one I've used before, I put a check mark next to it. And the ones that have the most check marks, you learn the most about. Same thing with the diagnosis. This has this, how many people have diabetes, osteoarthritis, and this, and digestive problems. Check mark. Those are the diseases you have to know most about. Makes a lot of sense. So, absolutely true. That's the kind of stuff that I learned more in 8 weeks in that summer than I did probably in 2 years of medical school. Just being on the floor all the time and just playing sponge, soaking up all that stuff. The sarcolemma is the lining. So in skeletal muscle, it's T tubules. Here, they have a great name. They're called caveolae. You're going to see 3 names that all begin with Ca. Calcium. And the infoldings that are kind of like taking the role of the T tubules are called caveolae. And they bind not to troponin. There is no troponin. They bind to calmodulin. They all start with Ca. Remember that. So you're going to see the caveolae. Here's a very good illustration. There's a little bit of calcium stored here in the sarcoplasmic reticulum. Same way that it was in skeletal muscle. Yes, it's got a channel that opens and it comes out. But here, that impulse goes along the skeletal muscle from those neurotransmitters, and it opens, yes, another one of these voltage-gated channels. In the caveolae, the calcium comes in, and what you're going to see in a subsequent illustration is it attaches itself to a protein called calmodulin. That kind of takes the role of troponin, and it facilitates or enables the contraction to occur. We're not going to go in crazy like with skeletal muscle, where it's kind of important to know about it. It just makes it happen. So smooth muscle fibers are electrically connected. Skeletal muscles are independent. And that's why when you get that segmental basis, while one's contracting, it's telling the next group, get ready, and the next group, and then the next group, because it's sending signals. When cells send signals to one another, they typically use these gap junctions, little openings for chemicals or electrical current to go through. You don't see the striations. There are no sarcomeres, but you do have the thick and thin filaments. That's and the overlapping is still the same, which causes the contraction is there. What happens, you have, as you can see, it's 13, a whole lot more thin than thick. The other was 2-to-1. And they're arranged differently. There's no troponin. So there is tropomyosin, but this calmodulin, again, Ca, calmodulin, after the calcium enters by way of the caveolae, bonds to the calmodulin, it changes shape like troponin did, and eventually it results in the contraction. I know it's complicated, but there's probably between 5 and 10 questions on smooth muscles. The rest is all skeletal muscle on this test, I would think. So proportionally, you should study it, but it's not the point of emphasis. I tell everybody the same thing. So here's what it looks like. What they have, rather than having that sarcomere and the Z discs and the way that they were arranged and all the titin and all the other stuff that was in there, you got this. You have one cell. It's kind of, again, it's got the spindle, narrow at the edges, wide in the middle. It's got one nucleus. These little dense bodies, they're like anchor points, and you have these what are called intermediate fibers, which are very, very strong and don't dissolve, basically, and they call it a lattice work arrangement. That's the structure. The dense bodies are like the Z discs, the anchor points. And so what happens when there's a signal arise with the neurotransmitter, it releases the calcium, okay? And you can see the difference. They're talking about the spiral arrangement of the filaments. They're talking about the lattice arrangements of the intermediates and the dense bodies and the dense bodies and the Z disc. And when it contracts, it kind of gets puffy. See what I mean? So and spindle, it's like doing this. That's how it contracts. When you get to micro, if you're taking it, certain bacteria, that's how they move. They do this. They're called spirochetes. They like little corkscrews. The most famous causes a terrible venereal disease or sexually transmitted disease called syphilis. The other one that's very common around here, I'll bet you've heard of the disease, it's called Lyme disease. It's a bacterial disease. And that's the way that bad boy, once it gets in your system, moves around. And so there's a fair amount of information from that. Other than that, we're almost done with this section. I guess, I figured about 45 minutes or so. There's not a whole lot here. I'm not going to show you the pictures. This is just pointing out the differences. This is the skeletal muscle. We're not doing the cardiac, but you can see they're similar. But this is relatively simple. You've got the muscles and endomysium. You don't have the sarcoplasmic reticulum. You don't have the T-tubules. They just have those caveolae, just those little sort of infoldings in the sarcolemma. You can see how they're spread out. The spindle-like muscles rather than that multicellular fiber. Here's the calmodulin. None of that is here. The calmodulin is the one that you're going to see it changes shape, and it's going to cause this contraction. Then, effectively, that's what will make it contract. They're slow. Some cells act as pacemakers. We'll see a lot of that when you get to the heart. But a lot of the actions that go on inside of us, which we don't have any control over, it's almost like rhythmic contractions. And that's because they have a mechanism that'll start the contraction. That's there. It acts like a pacemaker, sort of like the analogy would be a metronome, that thing. So contraction is similar. You have actin and myosin. Calcium plays a role. Even the intracellular plays a role. It stops when the calcium isn't there, and it takes energy. I'll buy all of that. The difference is calmodulin. You don't have to worry about these kinases, the way that it works. So, I mean, really, and to relax it, same thing. We have to detach it. It takes energy. We have to transport that calcium back where it's held inside and pump it out, most importantly. And so you'll see it here, this this is basically what shows you. Here's the impulse. Calcium gets released into the cell, and it causes a shape change in that calmodulin. This is the kinase thing you don't have to know about. And effectively, it causes that to contract. And that's it. That's really just going to shorten it. Very efficient, just like skeletal tone. We have smooth tone. Okay. The ATP is aerobic in origin, so it's something we're making all of the time. These muscles, they're really all about endurance. Skeletal muscles are about power. The heart is the best combination of endurance and power because it just beats continuously. Smooth muscles are continuous, but they're not powerful. So they don't generate the kind of strength. They're regulated by a variety of nerves. And none of this is important. Again, you're going to see a lot of this about how chemicals work. I mean, this is one of the things, and I just like to, it has nothing to do with this, what we're learning about. This do with when you get to respiratory. People don't understand certain things. A lot of the way muscles work is based on changes in pH, changes in chemicals, stretch receptors. It's not always about the obvious. Most people think, what makes you breathe? Why am I not getting enough oxygen? No. The trigger for breathing, you don't have to know that for here, is carbon dioxide. When too much of that accumulates in your bloodstream, and particularly then into your cerebrospinal fluid, that's what makes you breathe. What CO2 does when it's too much of it, it lowers the pH, it becomes acidic, and that forces you. It's like the little kid says, I'm going to hold my breath, and I'm going to die, and you'll be sorry. Oh, go ahead. What's going to happen is they're going to faint and they'll start to breathe again. The little kid throwing the tantrum. Yeah, like that. Go ahead, knock yourself out. Call me in the morning. So understand that's how, if you free dive, you want to go deep, you do 3 cleansing breaths, deep exhales to try to purge as much carbon dioxide, because that's what you want. That's what makes you inhale, if you didn't know that. So that's all those. I haven't done that kind of diving in a while, or gone underwater for long periods of time. So I think that's really important just to remember going forward, and the rest of this is not. None of these units, we're done with this. That's the end of muscle. I'm going to take my voice about, and at 4 o'clock, I'll do the rest. 3:51. So we'll do a brief stop here, I think.